Hi, welcome. Nice to welcome you to the APP to APP virtual lectures. Uh, Tonight we have two audiences, the APP to APP audience, as well as the My Catholic Doctor audience. So welcome to both groups. And I want to introduce myself and thank you for being here. My name is Brian Bezick. I think you should be able to see my name on the screen. That's me. I work just outside of Boise, Idaho, and I do pulmonary medicine for a pretty large community health center out in the Boise area called Terry Riley Health Centers. Been doing that for quite a while, and I've been teaching respiratory medicine for quite a while as well. I've done one talk here already on asthma, so if you want to get an update on the asthma guidelines that have come out in the last year and kind of an update about what's been going on the last few years, you're welcome to do that, and that is available online and would love for you to have a look at that. Today, though, we're going to do COPD. Often those two kind of diseases get mixed up in our head, and we have different file cabinets for those two. But we're going to do COPD. If you did hear my asthma lecture, the first few slides of both of these are very similar because the medications are similar. When you have three classes of medicines, generally, and those are the same three classes for two disease states, there's a lot of overlap and there's a lot of confusion. And we feel like, well, the inhalers are going to be the same for asthma and COPD. While the classes are the same, the inhaler choices, especially initially, can be very different. So we're going to look at that real quick, and we're going to start with just kind of setting the groundwork. That is my name and my phone number and my email. And you are welcome to reach out if you have questions about COPD. Happy to answer questions. I also do a lot with alpha-1 antitrypsin and deficiency. If you have questions about alpha-1, happy to answer those as well. I have alpha-1. I'm an alpha-1 patient. My whole family is. And I test and treat that. So happy to answer questions about that. That is some of my speaker release notes there. I do work. I have done stuff recently for AstraZeneca on an ad board, but I'm not going to bring any of the things that we're doing into this particular talk today. So there's nothing I'm going to say that's conflicting, but I have done that recently. Today, what we're going to do, there's new medication classes. Well, the medication classes aren't new, but there's some new inhalers in those medication classes. So we're going to review those, set the stage for COPD. What do we got here? What is this disease state? What options do we have for therapy? And how do we know what to pick? Because there's a lot of inhalers, and you're going to see a big slide in just a second of all the inhalers. And it can be overwhelming for sure. So we're going to do that. Then the GOLD guidelines, which we only have one set, which is better than asthma, because asthma, there's a couple of different sets of guidelines. For COPD, there's one. We're going to review that one. It's GOLD. It's updated annually, and they've made some big changes. In fact, if you haven't looked at them in a while, they're very different. In fact, GOLD decided to get rid of some of the alphabet. We're going to go to that. Like, they got rid of 2 letters. They just deleted 2 letters from the alphabet and said, don't use C and D anymore. Why did they do that? Why would they take away letters of the alphabet? Well, there's a lot of reason behind it, and there's a lot of thinking and data behind it, and we'll get to that. So stay tuned for that part. And then there's some tips for just making COPD. Just how can you get to the next level of care? What things are we talking about? What's kind of the newest stuff? But also, how do you just take care of COPD patients better? And I have 3 areas that I'm going to hit on at the end as well. And so that's where we're going. That's our plan for today. This just is the big picture. If you look at all of those areas on the right, my right, where it says pulmonologists, that's where the pulmonologists are. And those counties, if you look down at the bottom of the little graph, some of those counties have 1,000 to 2,000, 3,000 patients with COPD and no pulmonologist for miles. This is something that PAs and NPs in primary care have to deal with. And those that see internal medicine, most subspecialties have to do this. There's just not enough pulmonologists to go around. Asthma and COPD are the 2 big, respiratory disease states that we have. Asthma is this constriction and airway inflammation and mucus, often tied to allergies, can be present when they're young. COPD, very different. Tissue destruction, right? Chronic cough, and most often, due to exposure. The one exception is alpha-1, which is genetic. I'm not going to keep saying that exception part. So just know that throughout this talk, when I say it's due to tobacco exposure or environmental smoke, I am leaving off alpha-1 on purpose because I just don't need to say that every time. But it is a genetic form. COPD, chronic, long-term, weak, floppy lungs. That's kind of how you got to think about it. We're not born with COPD, again, unless it's alpha-1. I said I was going to do it, and then I did. We usually find that over time, exposure to noxious gases or environmental smoke or occupational exposure leads to tissue destruction. The actual tissue is gone or it's weak, and the elastic lungs that should be tight and expand and recoil automatically, they don't do that anymore. They're not tight and rubbery, they're floppy, and I get big lungs that are overinflated. That's COPD. So chronic disease over time, tissue destruction, breakdown of alveoli, all of this can be part of COPD. Big, hyperinflated lungs. They get big and air doesn't go in and out normally. And when it does get in, instead of the elastic recoil pushing that air out, it sits. It just doesn't get out. And it's trapped. So it's trapped air, retained air that doesn't circulate well. And that maybe at rest, that's not a big deal. But boy, you try to do anything, you try to do laundry or go shopping, and it's a big deal. Just a great chest x-ray of normal lungs versus big open lungs, flattened diaphragms, wide lungs, just throughout the whole lung fields, you can just see that these are bigger and not taut and not tight and not restrictive and not moving air in and out like they should. All right. So just a kind of big picture of what COPD is. We're going to come back to the definition in just a second. This next little bit is on the medicine. So if you saw my asthma talk, it's kind of the same thing, but it's a very good reminder. 3 classes of medicines. There's 3 types, and it's the same 3 for both disease classes. That first class is just albuterol in some form, long or short, all right? Short acting is albuterol. We're very familiar with that. Onset of action, maybe 30 seconds to a minute. Duration of action, maybe an hour, maybe 2, maybe up to 4 hours. How long it lasts is kind of inverse to how sick you are. The sick you are, it doesn't last as long, right? People will tell you that. My inhaler just only lasts a half hour. It's because you're fighting something, okay? If it's long acting, it's just albuterol, but it's long acting. So albuterol, it's a short acting bronchodilator. It causes a bunch of things to happen at the smooth muscle cell that causes it to relax. The calcium level drops in the cell, and the cell relaxes and releases and opens up and allows air to move in just more easy. There's less resistance. The diameter of the lumen gets bigger. Air resistance goes down. You have better flow, less turbulent flow, more laminar flow of air. And the end result is that you're breathing better and easier. Salmeterol, formoterol, valenerol, all those are the same as albuterol. Those are just albuterol, but a form that lasts maybe 12 or 24 hours. So I think it's good to tell patients, hey, I'm giving you an inhaler and it has a long-acting form of albuterol. It's just what you're used to, but it lasts longer, okay? I did put this up there, so you might want this. If you want the inhaler poster that I'm about to show you in English, you can pause this and put that on your phone, and it will take you to a picture of that. And then if you want the same inhaler poster in Spanish, that's the QR code for that. So sometimes it's easier to have it on your phone so you can actually look at it, all right? So those 2 I just put up. This is the inhaler form, all right? So this has all of our respiratory inhalers on it. This can be had no cost to download this PDF from the Asthma and Allergy Network. Their name is in the upper left-hand corner of this little picture here. On this slide, that is the albuterol. So albuterol in some form that's quick acting, whether it's a nebulized solution or an inhaler, those are just albuterol again, but in a form that lasts 12 hours or 24 hours. So that's a long-acting albuterol. The 2 on the left are in nebulizer form. The 2 on the right are not, right? One's a mist inhaler and one's a dry powder inhaler. That box is the inhalers that have albuterol in a long-acting form, right? A long-acting form of albuterol with something else, okay? So they're going to add another medicine to it, all right? So those are those 3 classes. Those 3 categories, sorry. The next class is the steroid class, all right? So we've got albuterol, now we've got steroids. All of them are long-acting. They're not really short or long-acting in this regard. And these just reduce every aspect of inflammation. Corticosteroids bind to the receptor, mediate changes in the genes, actually how cells work at the genetic level, and these lead to multiple downstream effects. The main take-home point here is that steroids reduce almost every aspect of inflammation. Steroids don't care why you have the inflammation. They're going to reduce it. Now, some forms like eosinophilic inflammation is better reduced by steroids than maybe neutrophilic, but all forms of inflammation get hit by steroids. Now, they don't work super fast because they got to get into the cell to do it. Many actions, central goal, reducing inflammation, okay? This is the set of inhalers that have just a steroid. So if you want your patient to have just an inhaled steroid, those are your options. If you want an inhaled steroid with albuterol, but in this case, a long-acting form of albuterol, that's your choices, okay? If you want all three categories, which we haven't done the third one yet, then that is your category right there. That is all three of these categories. All right, last little part of meds here, and then we'll get into COPD more, is the SAMAs and the LAMAs, the short-acting and the long-acting muscarinic agents. These cause constriction to release, so relaxation of muscle. They actually prevent it, which I'll show you in a second. They also dry up mucus secretions. These are anticholinergic. So they have a bronchodilator role and kind of a drying up mucus role, and very helpful. And you'll see in a second, very helpful for COPD. So ipratropium bromide is our only short one in that category. So that's our only SAMA. And then there are a variety of long-acting muscarinics, okay? These are anticholinergic medications that dry up and help prevent constriction. If you want your patient to just have that category, those are your inhalers, all right? So you've got two short-acting forms in that category of the SAMAs, all right? Combivent is a mist inhaler that has albuterol with ipratropium, and then the little vial there is just ipratropium, bromide, and albuterol in a nebulized form, which is brand name Duoneb. So those are the short-acting ones. If you want a long-acting one by itself, that's your options there. Okay, so we have medications that are just long-acting muscarinics. This kind of is there's a lot of inhalers here. That's why hopefully these categories make sense. If I would like to take a long-acting muscarinic, so that third category, and add it to a long-acting albuterol, right? Then I've got those four choices. I've got a mist, and I've got an MDI, and then I've got a dry powder. Those are LAMAs and LABAs together. Then this last category in the middle is all three. So if I have all three of those classes together, that's a triple inhaler. All right, we've got Trelegy and Breztri are the two options in that category. So 3 categories of medicines. The way to think about these with asthma is that you start with the albuterol category and you move to the steroid category. And then if you're going to proceed, you can proceed to the LAMA and the SAMA category. So that's kind of the procedure, the steps that you take with asthma for these inhalers. Okay, there may be other steps you take, but that's kind of the flow on this chart. For COPD, we skip the steroids. And so that's the big first take-home point. The guidelines for COPD are clear. We want to use the albuterol category. Benefit is there. Downside is minimal. And we want to use the LAMA category. Those have they're very efficacious, and I'll show you some of that data. And the downside is minimal with these. Dry mouth is one of the most common side effects, and that's about it. There are other ones. I'm not trying to downplay that, but most people do very well on a LAMA-LABA inhaler. Then for some, not the majority, but for some patients with COPD, we do add that third category, and we add the steroid category, and those are the triple inhalers. Those have a big role with COPD, and they're important, but you want to make sure that you're choosing a patient that makes sense, because steroids bring a downside as well. So when you get to that steroid category, you got to weigh the pros and the cons, and GOLD tells you how to do that, and I'll show you. This is a reference, just a reference slide, so you can see the different inhalers and the shapes and the types and whether they're in dry powder and kind of what they do. So I wanted you to have that. That's the inhalers, and that's the medicine. So we'll kind of take a deep breath and pause. 3 categories of medicines. Our choices initially are albuterol with a long-acting muscarinic, and then for some, add that steroid. With COPD, we have these 1 guidelines, thankfully, that kind of one guideline to rule them all. I mean, it's the Lord of the Rings here, and this is the 1 guideline to rule them all. That's the 2024 report. You can download a shortened version for free if you'd like it. There's an app on your phone. They do a good job. Lots of good resources. COPD, a common preventable disease, progressive and associated with what? Chronic inflammation. This is inflammation, tissue destruction in the lungs. It's usually due to exposure to noxious particles or gases, typically tobacco smoke. And then I underline this part because exacerbations and comorbidities contribute. And that's Gold's main two goals the last few years has been, one, to reduce steroid use because patients don't need it often, and then to focus on the E, which is exacerbations and a little bit on eosinophils. So this is a big focus point for COPD treatment. This, just lots of data here, but just follow that red line across. It doesn't matter which study or which country you're referring to. This just shows you how underdiagnosed COPD is. And it doesn't matter which study, everyone says the same thing. 70, 60, 70%, 80% of patients with COPD are missed. So lots of patients undiagnosed, and yet there's so many of them already. So this is a huge problem, one of the leading causes of death. We're all treating it, and this hopefully helps you just do a little bit better job. We're going to take a few minutes and talk about diagnosis, okay? This is a little bit more complicated than asthma. At least I think it's a little more complicated. When you want to diagnose COPD, a lot of times it's pretty obvious that the patient is at high risk. They have a long smoking history, a long history of chronic coughing in the morning and mucus production and flares and all that. So you kind of know. If you see somebody, dyspnea that's progressive, chronic cough, chronic sputum production, do they have a history of risk factors that make me wonder? Maybe there's a family history. Those patients you want to try to diagnose. With COPD, we have one option, and that's spirometry or PFTs. That's it. There isn't really another way to diagnose. There's not an alternative path. On the asthma side, Gina has said, hey, if you can't diagnose with spirometry, there are some things you can do instead. They really don't have that for COPD. So spirometry or PFTs are required. This is just a diagram showing you what an FEV1 over FVC less than 70 would look like on a spirometry exam. So this just showing you, in a representative form, like if there's normal lung function versus somebody who has reduced lung function because their FEV1 over FVC is less than 7.7 after they've had albuterol. Come back to this in just a second. All right. First step, diagnosis, doing spirometry or PFTs. That's it. When you do that, I'm going to highlight that little box right there. When I diagnose somebody with COPD, I'm going to compare them to themselves. In other words, how much air do they have? That's their total lung capacity. And then of that, how much can they get out in the first second? So if somebody has 4 liters, picture 2 2-liter bottles. So I got a 2-liter bottle and a 2-liter bottle. They've got 4 liters of air. Of that 4 liters, how much can they get out in 1 second? All right. So they have 4 liters and they got out 2 liters in 1 second. So 50% came out in that first second. What Gold is saying is if that's less than 70%, and that one was, then they have some form of obstructive disease. All right. So that's how I diagnose it. Now that's after albuterol. I don't want any bronchoconstriction kind of interfering. I want to give them albuterol, and then I want to measure how much of your air do you have and how much of that air can you get out in 1 second. So that's the FEV1 over FVC. That's comparing the patient to themselves, okay? How well can you exhale? How quickly can you exhale? Are your lungs rubbery and tight? So when you inhale, the recoil is there and air flows out easily, and the airways are big and they're not clogged with mucus and they're not floppy. You don't have some bronchiectasis. You don't have something going on obstructing the airflow. When that happens and I can't get the air out quickly, that's obstructive disease. That's COPD. So that's the diagnosis. Once you have that, then you stage them. And the staging, where you have Gold 1, 2, 3, 4, this is where it's kind of confusing. The diagnosis is them compared to themselves. The staging says, hey, how do they compare to a peer? So I'm going to stage them 1, 2, 3, or 4 based on how much they have versus how much they ought to have. So pretend your patient has a next door neighbor that's the same age, height, weight, gender, and ethnic origin. Exactly. Kind of weird. Okay. But how much can they get out? Like how much air can your peer get out? If your air is obstructed compared to a peer, then that gives us the stages. That's kind of the bad news. There's lots of numbers here and it's kind of overwhelming. The take home is you need to diagnose this. if you send them for spirometry or PFTs, you'll get this data back, and the data will say FEV1 or FVC was 80%. It's normal, or it's 62%. They have obstructive disease. Did they reverse after albuterol? It'll note that. And so you can look and see, do they have it, and what's their stage? That's how to diagnose. Spirometry equals diagnosis. However, so that equals diagnosis and grade. However, once you've done this, and I would say once, I mean, you may do it again, but really don't worry about it. Get it once. Once you do this, then you get to forget about it. All right. You get to absolutely, I don't care anymore. Once I have the diagnosis and I know what I'm up against, and I know I have a confirmed diagnosis and I'm not missing some fixed airway obstruction. I've got COPD. FEV1 over FVC is less than 70. I know what's going on. Once that's the case, then I can forget about it, because spirometry doesn't equal treatment. And that's the take-home point. It doesn't equal treatment. For a long time, we thought it might. Like, how are you doing on your spirometry? That'll tell me which inhaler. So I've got my inhalers here. So this inhaler, which the one you get, depends on your spirometry. But that doesn't work, because the spirometry does not equal how are they? How long will you live? Can you chase grandkids away? Around, I meant to say. Or chase them away. That would be good sometimes. Can you do the things you want to do? Can you go bowling? Can you go shopping? Can you do your laundry? Those things weren't tied to spirometry. They were tied to how are you and how often are you sick, but they weren't tied to spirometry. So we're going to set that aside. This is, you need to do it. And then you say, okay, I'm not going to worry about this anymore. I'm going to ask them, how are you? How are you doing? How's your breathing? Are you doing the things you want to do? Are you sleeping flat? Do you have to have 3 pillows or on the couch? Can you go shopping? I need to know how you are, because that will tell me what to give you. All right. So that's the diagnosis. But just like with asthma, we're going to set this aside and ask them, how are they? All right. I suggest doing this before you go in the room. If you can have this done before you go in the room, I think you're better off. All right. So put them in the room, have your MAs or nurses give this to them, and then you come in and you get a score. This is one of the tests. There's other ones, but Gold likes this one and I like this one because this gives me a really good idea, and it only takes a couple of minutes to do. So quick review. All right, let's take a deep breather. COPD, widespread, largely underdiagnosed, and you and I, we have to treat it. There's not enough pulmonologists to go around. Most are tobacco related, but there's others. Anybody who kind of fits the bill, cough, chronic mucus, they have a history, whatever, you need to get them diagnosed. You need to do spirometry and diagnose them, okay? But the stage, the number you get does not equal quality of life, and it doesn't mean how they're going to do, and it doesn't tell you really a lot about what their prognosis is. It tells you where they're at and helps you with the diagnosis, but I need to know how they are. How often are you sick? And thankfully, that's easy to do. We can have that done before you go in the room. And the time it takes to assess and decide what inhaler to give for COPD, I challenge you that would take less than 30 seconds every time. Maybe not the first visit and you got to get some more information. But once you're done, you don't really need to repeat it. I mean, you might repeat the PFTs, but don't worry about it now. Just you want to know, how are you? How often are you sick? Because what Gold says is that the really amazing COPD treatment providers, those providers that are doing A+ work, are the ones who get the diagnosis and then ask those questions. How are you? And how often are you sick? If you want to just ask them, that's fine. If you want to give them a questionnaire, that's fine. This is the big diagram that Gold will show you, okay? And those two are that whole diagnosis. And so I don't care about it anymore. Why? Because I did it. I care, but I did it. They have COPD and they're Gold too. Great. I can put that down in some insurance form, and that may help with disability. I don't know, but it doesn't change what I'm going to do. I'm going to take the other part of this graph and blow it up. This is what I care about. And this takes no time at all. This is the easy part. I think this is the fun part. On the left side, it says, have you been sick? 2 times in the last year, or 1 time in the hospital? Okay, then you're on the top. No, or just once? Okay, you're on the bottom. Then this CAT score is on the bottom. You can see where it says CAT less than 10 and CAT over 10. You can do the modified research council one, or that's fine right there. That's 0 to 1 or 2. Either one. Or you can, there's a pulmonologist I work with that says she just asks, Can you walk on level ground at a comfortable speed without getting out of breath? And she goes, if they can't, then I put them on the right. If they can't, I put them on the left. Fine. I mean, just you're trying to find out how they're doing. These little letters then will tell you what to give them. Prior to last year, we had A, B, and C and D. And Gold said, no, we're going to get rid of these two letters. We're going to delete C and D from our alphabet, and we're going to go right to E. And the goal with this is twofold, maybe three, but twofold. One is to really, again, emphasize not to use steroids. The other one is E, kind of standing for exacerbations. I think it's nice, too, to remember eosinophils, so it can stand for either one of those. So that's the letters, if they're an A. So, hi, Mr. Jones, Mrs. Jones, we tested you. Your FEV1 over FDC was 55. You have COPD, and you're not sick that often, and your CAT score is pretty good. You can do most of the things you want to do. You're in the A, and I'm going to provide you with a bronchodilator. That's a short-acting bronchodilator. Here's albuterol. Here's how to use it. See how you do. I'm going to see you back in 3 months. Group B, same thing with the sickness side, the illness side, but on the right side, now they're symptomatic. Now they have symptoms. Their CAT score is over 10. They can't walk on flat ground at a comfortable speed. I need to add something. I need to take some steps to help them feel better, do better, get sick, not necessarily less often, but less severe, reduce the duration of their cough, and improve life, quality of life, okay? Gold has a very nice data set. I don't think I have it on these slides, but a very nice data set that lists all of the kind of the meta-analysis of what do LAMA-LABAs do. And the data is impressive. And the side effect profile is it's impressive as well. It's very little. If they're E, that means on the left-hand side, they're sick 2 or more times or 1 time in the hospital. And then if that's the case, then Gold says don't really care about what their score is, because that person, they need help a lot. They're sick a lot, or they were in the hospital once. I'm going to start treating them more aggressively. But you notice, we got a problem. It's the same 2 medicines, LAMA-LABA. Gold says, yes, LAMA-LABA, that's your go-to if they're in this category and their eosinophils are over 300, then consider a steroid. And I'm going to come back to that, okay? So they took steroids off of all guidelines except for to make them an asterisk right here. So you can see that little asterisk right there, and it's saying, hey, consider it, but we're not even going to put it, we're going to put it as a footnote to try to get people. 80%, and this data back, I don't have the data up on the slide, but about 80% of patients with COPD that are on a steroid don't need it. They get put on whatever. It doesn't matter. I'm not picking on an inhaler here, but Advair or whatever. They get put on a steroid with a long-acting beta agonist, and then they just get left on it. Most patients that come to me for referrals, number one, don't have spirometry done, and most are on a steroid. And so I get my first step, first day, every day, is to set them up for PFTs and to stop the steroid. That's what I do most of the time. All right. So this is the big picture for the initial pharmacologic treatment. Remember, I'm going to diagnose them, but the diagnosis doesn't tell me what to give them. What to give them comes from this. And it's how sick are you? That's on the left. And how sick are you is, yeah, on the left. I'm sorry. And then how many symptoms do you have? How symptomatic? Can you do the things you want to do? That's on the bottom. This is just, I wanted to show this to you. This is a very good study, a very good compilation of a lot of data. And this, you know, anytime you see Cochrane anywhere, right, to convince the Cochrane people of anything, I don't know how they do it, but Cochrane says, hey, listen, don't give them steroids, don't do it. And this is why. And the take home is there's lots of downside, but the main downside, main downside is increased risk of upper respiratory infections and pneumonia, roughly double. And I just made a note that dry powder fluticasone is the kind of the biggest culprit, which is the one that you can find in brand name Advair or generic Advair or Wixela. So again, not a bad medicine. It's just in this patient class, it's not helping. And if you're curious, I would encourage you to read that. That's a very good meta-analysis. So when would you give them a steroid? This is Gold's guidelines right here. This is Gold says, if they're category E, you're going to think of exacerbations and eosinophils. They say, look, you probably should really consider adding a steroid if they're sick a lot, their eosinophils are over 300, history of asthma. Those patients should be on a triple inhaler. All 3 of my categories, we have 2 triple inhalers, And though either one is fine, okay? And whatever's covered by insurance. Gold says, yes, put those people on. That's about 20%, between 15 and 25%, depending on what population you're looking at. May be considered if they have one severe and their eosinophils are 100 to 300. Do not use it if they have sick a lot, low eosinophils, and anybody that has a history of, so mycobacteria, any form of that they want to have. I mean, if they have any kind of anything in that category or history of mycobacterium, or you have a kind of suspicion for that, if middle-aged or older female and this kind of abrupt change in their cough of the last few months, maybe they visited the coast. There's these other risk factors for mycobacterium infections. And so if you see MAC anywhere in their history, they should not be put on a steroid unless they absolutely have to have it. So this is a lot of patients that don't need steroids. That's a take-home point with this one. All right. So where are we at? Get the diagnosis. That's spirometry. Then you're going to say, how are you? How are you? How often are you sick? You can give them a questionnaire or not, whatever you want to do, but get that information. Then you decide what inhaler to use, A, B, or E, what category. If they're in category E, could they be on a steroid? Maybe. Do they have higher eosinophils? Are they sick a lot? Does it make sense? Do they have asthma with it? What am I going to use? Then, once you do this, then you can become a superstar, okay? So that's my pause right there, and I just have a couple other things I want to do, but you know the categories. We've got this diagnosis, set that aside, A, B, and E categories. We're going to decide if we give them a beta agonist, a LAMA-LABA combination, or maybe for some, a triple inhaler, if they meet some criteria. That if you go to that point, you are already doing more than most. I see referrals every day, and I spend a lot of time going through their chart. I spend a lot. I go through all the way back as far as I can find. I want to know what their CBC has said. I want to know their eosinophil levels over the years. I want to know the meds they've been on. When I look back, those things aren't done. They're just not getting done. So if you do that, that is amazing, and you're busy in family practice, that's great. These next three things I'm going to point out, if you have time and you're interested and you want to go to the next level, that's what we're going to talk about. So keys to kind of future, where we're going and how to be a superstar. Key one is exacerbations. It's a huge part of COPD, and it's a huge part of what Gold is focusing on. Take home point initially is these are not bumps in the road. With asthma, exacerbations are usually something they can get over and get back to. COPD, it doesn't happen. Every one of your COPD patients that has a flare-up that needs treatment, they just lost lung function. They went backwards and they'll never get it back. This is a one-way road. It does not come back, all right? An exacerbation is an acute change in their baseline dyspnea, cough, sputum, color of sputum, amount of sputum, and it's beyond the normal variability and they need treatment. That's the definition. That's the ATS definition of what an exacerbation is, okay? That's just ATS. This is a diagram kind of showing you what happens. They get sick and their lung function goes down and down and down, and they never recover. They lose some lung function with every infection. And with the severe infections, and patients will tell you, I was doing great until I got COVID or got flu or got RSV or whatever, and I've never been the same. And that's exactly right. They're not. So this is the seminal events in their life. These are the things we have to try to avoid if we can. So exacerbation prevention and treatment they're pretty much the biggest focus Gold has right now. Causes, what makes up an exacerbation, most are viral, almost all are viral. There's other populations where it's maybe not quite this high, but most of patients, it's 80%. There could be bacterial, smoke, cooking, exposure, something like that. Or they ran out of meds, like they didn't have any meds for a while. Non-compliance, they couldn't afford them, huge part of it. But viral infections in the last 6 months, I have the same, I'm just on autopilot with patients, talking to them about, I don't know really, I don't think I care much what virus you had, because if they come in on day 5, I'm not going to give them an antiviral most of the time. I'm not going to give them Zofluza most of the time or Paxlovid. They're not going to get those things because we're past that. So what viral insult they have, it's important to some degree, but really it doesn't change what I'm going to do. You got sick 5 days ago. You're here now because you can't breathe and you're having an exacerbation. I'm now going to approach this and treat it the same regardless, all right? If it's RSV, maybe I talked to you about the fact that it might hang on a little longer. If it was flu, maybe you had more body aches and chills. There's just there's kind of these hallmarks of some of these viral infections. And when I get a viral panel, it's interesting, but it doesn't change much, all right? So in some ways, it doesn't really matter. When they have a flare and they come in for treatment, you're going to use steroids. We do almost every time. This is oral, right? And I'm just going to encourage a couple of things. Lower is almost always better. Slower and lower, or shorter and lower. I really like 40 milligrams for 3 days and 20 for 3 days, or something like that. That's just, there's no data behind those two numbers. That's just what I do. And what I will say, there's lots of data supporting less duration, just a reduced duration. Non-inferior studies where you compare 5 days to 10 days, the 5-day studies say it's just as good. Nebulized dose packs are fine, and I see that, but they can be really expensive, and I never write for those. I haven't written for a Nebulized dose pack in probably 7 or 8 years. I like prednisone. It's very inexpensive. I give them the 20 milligram pills. They can break them in half. They cost $2 or $3, and most patients tolerate it well. If they tolerate Nebulized better, that's fine. I like the patient-controlled taper. Here, Mrs. Jones, we've done this before. Here's 10 pills or 15 pills. Let's take 2 a day till you're halfway better. And then take 20 till you're close to normal. I'll let you control the taper. I'm not giving you enough pills to do any harm anyway. So maybe you can get off it quicker. Maybe you feel better quicker. Maybe you need to have that tail be for 5 days. Okay, that's fine. Give them a little bit of autonomy. I have a written COPD action plan that I give them. Macrolides, you can use doxy, but macrolides are better, and the data's there, and I have a little bit coming up, should be used for most flares. I'll just say that it's a good way to go for most flares. You can use it without prednisone. Macrolides, most of you know, are a very good anti-inflammatory. Look at the reduction in some of the inflammatory cytokines and some of those markers for inflammation that we can measure, and they go down, not as robust as they do with prednisone, but they go down with macrolides. So a very good option. You can talk to them about using azithromycin by itself or with prednisone, depends on how sick they are. So, and you could consider this a little bit longer. I have no problem putting them on azithromycin for 2 weeks if I think they need it. Maybe prednisone for 3 or 4 days, pull them off that, keep them on the macrolide. There's a lot of nuance and a lot of art here, but there's strong data to back up all of these things. How exactly we do it, I think there's still some art to it. And then have them increase their as-needed medicine, right? Hey, you have a DuoNeb. Let's go ahead and do that every 6 hours at home or every 4 hours at home today and tomorrow. Then in 2 days or 3 days, go to as needed. So let's do it on the clock. Let's not let you get out of control and then try to pull it back. All right. And then you can control cough if you want. If you can provide something, people use, Mucinex DM or guaifenesin. I just put this up here when I give these talks because I think it's interesting. I would say, does anybody know what Tessalon pearls do, what benzonatate does? I was in a room, it's about 80 people, and I asked, and not one person could tell me the mechanism of action of benzonatate, which I thought was interesting because we give it so much. It's a topical analgesic. So think about that. It's a tickle blocker. It kind of helps that tickle, but if it's a thick phlegm trying to get it up kind of a thing, benzonatate is not going to do anything. You can use it. I think it's pretty safe, people like to have a prescription. So if you want to do that, but it's not super helpful if you got to get up. If it's a tickle, I think it can be helpful. All right. So that's number 1, exacerbation prevention. And I think maybe I took the slide out. So preventing these is vaccinations is kind of the big one. All the things we do with COVID, isolation, mask wearing, washing hands, but kind of the one that we can control maybe easiest or the biggest intervention is vaccination, getting them their RSV vaccine. That's so big. And probably I would say that we're going to see that 2024, the winter of 2023 and 24, probably RSV is going to have a bigger morbidity and mortality burden than either influenza or COVID. That's just a guess. That's just my guess, but it may not be, but it's close. All right. Number 2, got 2 more of these and then we're done. You did it. You stuck with it the whole time. Switching to nebulized medications. This is a very good review article. When should you consider, why would you do this? Why? And the thinking is this. I like this a lot. If you have a patient with COPD, ask these questions. So the brown boxes, if you will. First question, do they have a problem with cognitive function? I was just dealing with this on Friday, a patient who really struggles cognitively. They can't do their inhaler. There's no way that's going to happen with any kind of regular, but they can do a nebulizer. So impaired cognitive function and they don't have somebody to help them, nebulizer. Manual dexterity. It's hard to use these things. All right. Do they have problems with that? Put them on a nebulizer. All right. What if they can't inhale? What if they struggle to inhale the air? Put them on a nebulizer. All right. That's the thinking. And that's the data behind this is that somewhere around a third of all patients with COPD who have this, they can't use it. It's not doing anything. So we have gold and it's wonderful. And we want to ask them how sick and how they're doing and decide the inhaler and make the best diagnostic and recommendations we can. And we come up with this plan and we hand them a COPD action plan and we give them the right medicine. And maybe we put them on a LABA and we're doing it right. And they can't inhale it. They don't have the inspiratory capacity. It's not doing anything. All right. It's not getting anywhere. It's going into their mouth and sticking to the roof of their mouth and their tongue, and it's not going anywhere. All right. So think about that. Now, on the inhale part, the little device on the side is what I use, but I don't expect you guys to do it. But just so you know, it's called InCheck, and I can turn that little dial and inhale and see how hard they can inhale and measure inhalation capacity and see if they can inhale. If not, then I'm switching them over to a different inhaler, like a mist, or I'm putting them on nebulizers. Something you can do is, can you hear that? And I'm going to do this. I don't know if you can hear me. So this is an MDI inhaler. Can you hear them inhale? So let me show you. If they go, you can hear that. So if you're across the room 5 feet from them and you have them inhale, can you hear it? Or no, if they go and you can't hear the noise of the air coming down and into their mouth from the actuator, they're probably not inhaling enough to move that medicine in, especially if it's a dry powder inhaler. So that's just a tip you can do. I like the Post-it note. Can they hold a Post-it note to them? Can they hold it to their mouth and inhale and hold it there for a couple of seconds? If not, they may not be inhaling hard enough. Or you can have them come see somebody who can do InCheck and evaluate this. The other one is, do they feel like nebulized medicines are amazing and their inhaler does nothing? That may be a clue. All right. So step 1 is exacerbation prevention. Step 2 is to say, hey, can I get them on nebulized therapy? The nice thing about nebulized therapy is, voila, there it is. All 3 classes come in a nebulizer now. You can get them all in a liquid form. This is just a reference chart, so you can use that and look and say, okay, what options do I have for them? But all of them are available. And the other kind of funny, interesting thing with medicine, which isn't funny, I guess, in some ways, because it's a cost thing, but I would say most of the time when I switch them to nebulizers, the patient cost goes down. I don't know. Sometimes this ends up being on Medicare Part B, and instead of Part D, which makes a difference. But billing is not my strong suit. All right, we got one more, and then we're done. If you stick with me, you've got like 5 more minutes. So nebulized therapy, consider switching over. I really would encourage you, if you have a patient that's not doing well, and man, I don't know that they have the cognitive function. I don't know if they have the manual dexterity. I don't know if they're inhaling hard enough. See how they're doing. Switch them over to nebulized therapies. Tell them why you're going to do it. Most people are happy to do this. They have the time. They're not rushed in the morning. These aren't, 40-year-olds running to work at 7 every morning. Usually they can do this and they like it. It's not a bad thing. It's not a down thing at all. And I always have them switch mid-month. So I want them to have their inhalers still at home. I'm like, we're going to switch. If you hate it, go back to your inhalers. Okay, that's fine. I don't want you to ever feel scared like you don't have a treatment option that you like. So I want them to have their inhalers that they're used to right there, and they can turn right back to it. Okay, last thing is smoking cessation. Hopefully this is helpful. I try to be a little funny here too, but hold on, we'll see. Motivational interviewing is great, right? Stages of change, trying to decide if they're a pre-contemplator, all that stuff is really good. And I'm not discouraging it at all. I struggle with some of those things because, I don't know, because I do. I just do. I'm in therapy. I'll get over it. When this is ineffective, I scare them, kind of. I don't really try to scare them bad like this picture, but I think it's good to have an honest talk. So here's what I do, and here's some recommendations and then I'll show you some data in a second. What I show them their chest x-ray. If there's something I can see, I show them, and I sit down, I have it on my phone, and I show them big floppy lungs, flattened diaphragms. I talk to them about lungs that don't work and why and how scary it is to see. And that can sometimes be motivational. I show them their CBC. if you see a crit that's high or a red blood cell count that's high or hemoglobin, that's a very late sign. That means bone marrow, right, is responding to chronic hypoxia. And it's like they live in Colorado Springs or somewhere and they're pushing that hematocrit up. That is a very, very late concerning sign. And that tells me they are chronically hypoxic. And I talk to them about that. And I say, look, this is not good. This is your bone marrow trying to help you, and it will not compensate for long. All right. The other thing you do, you tell them their lung age. This is the thing, if you want to do it. That's the actual equation, which I never do, but I think it's interesting to see the equation. You can do that. I have a way to estimate it. That's pretty good. It's Brian's way. You could just take their age and then half their pack years. So, Mr. Jones, you're 50. You've been smoking for 40 years. They started at age 10 in this scenario. So half of 40 is 20. Add it to 50, and I say your lung age is about 70. All right. And then I say, well, Mr. Jones, most people will need oxygen around. And then I pick an age that's a little later than their lung age, like at around 75. I try to frame it. I'm not trying to be dishonest because this holds pretty true. And I'll show you the study in just a second. But I tried to tell them, hey, you're not that far off. If we're at this point where we're talking about these things and you're continuing to smoke, I want you to know that this is getting closer. And then oh, by the way, that's the data that you can reference. It's a Journal of Family Practice article from 2008 that goes into this a little bit more. And it talks about these things that I've adopted this a little bit for me, but that's the data. And then the payoff, I say, do you think you'd prefer like one of those oxygen tanks that you carry with you on your shoulder or one that you pull? I'm like, we could start kind of planning what oxygen tank you'd like now. And they just look at you and they sometimes will get a panicked look. And then they'll ask you for Chantix at that point, or they'll say, what can I do? Scaring them I say that word in jest. I'm not trying to scare anybody, but I have a very honest conversation. I show them the data. I talk to them about their lung age and I say, hey, we're getting close to you needing oxygen. Can you picture what your life is going to be like? Can you do this? Is this something that you're going to do? Is this something you want to do? I'm not guaranteeing you if you quit smoking, this isn't going to happen, but it's a much better shot. And most people, in fact, the vast majority they're happy that I had this conversation, that we talked really openly about where they're at, where they're headed, and that their future is one of limited activity, not doing what they want to do, and at some point being tied to oxygen. And they'll say, well, I'll never want it. And I said, yeah, you will. I don't ever put anybody on oxygen, ever. I don't keep them on it, let me say, that doesn't ask for it, because you know this, everyone does. If they need it and they're hypoxic and you put them on it, they feel so much better. They want it. Every patient wants it at some point. They don't want it, but they do. You know, and they're going to tell you, yeah, holy cow, I feel so much better on it. So I tell them you will. You'll want it. You'll ask for it. Once you get going, you'll want to stay on it. That's you. We'll decide that. So having those conversations and doing that, this is a very good review article from 2021. And I just want to point out one thing, and then we're done. I think this is the last slide. But if you look at the key points on this kind of review, they have 4 key points, and every point has the word varenicline in it. Chantix. It said every one of those points. And what you'll see in this article is that the data is that Chantix works. Varenicline works. It works very well. And nothing else really does. And you can combine it with other therapies. I often combine it with Wellbutrin. I often combine it with patches. I'll do with any other thing, counseling. I do, but I will get everyone on Chantix that I can. I can get it very inexpensively. And there's lots of ways to tweak this. I didn't put another. There's lots of ways to tweak this. If you're not familiar, just in 30 seconds, it comes in a starter pack. You get a 0.5 milligram once a day. You go to a 0.5 milligram twice a day, and then you go to 1 milligram twice a day. So you go from 0.5 milligram to 2. And what I tell people is those doses are meaningless to me. I don't care about any of those doses. I want the dose that will work and not have the side effects that drive you crazy. And sometimes that's a 0.5 milligram once a day. Sometimes it's 1 milligram twice a day. I have patients that do a 0.5 milligram 3 times a day. I'm not going to go over 2 milligrams a day, and nobody really needs that. But you can take less. So if they get too much and the side effects are nausea and just kind of feeling blah, really bad, or agitated, and it's too much and they're having some success, I back off. you can drop down to a 0.5 milligram. You don't have to go to the max dose. Everybody's different. I have a whole little plan that I go with them, and I just have them titrate up and down based on what they need. And then I have them stay on it as long as they want. I've had patients on it for 7 months. Great. I don't care. How long does it take you to get over the smoking and then change those habits in your life? Change what you do so that this can stick. And however long you want to stay on it is fine. And it's inexpensive and it's very safe. And I've had patients take a 0.5 pill or a 1/2 milligram a day for 6 months. Great. So play with the dose, give less, talk to them about it. And in the end, the side effects, which are there, but the side effects are very similar to quitting cold turkey. You want to eat everything and punch everybody, whether you take Chantix or not, same side effect profile. But I work with them on it. And if I really think there's a behavioral health aspect that I can help, I'll maybe put them on Wellbutrin for 30 days and then start this. Works good. I've done it. So that's what this article talks about. And they pretty much just echo what I just said. So the last 3 things: exacerbation, prevention, and treatment. Consider moving them over to a nebulizer. You can do a world of good. And if they're still smoking, be very forceful and upfront. Don't mince your words. Show them their data. And in the end, you may be able to help them quit smoking with a medication that works pretty well and is safe for most. You got to screen them, but it's safe for most people. And if there's no contraindication, consider giving it a try. There's my name and number again. If you ever have any questions, you can reach out anytime. And thanks for watching.